Okay, we'll start. So, good morning, everybody. Um, so I believe you've already had some lecture on hypersensitivity from pathology. Is that right? No? Oh, okay. So yesterday we completed our exploration of the basics of immunology, where you learned about all of the cells, the mediators, the mechanisms of the immune process. From now on and in next year, you'll learn about the role of the immune system within the body's normal physiological state. Right? Now, I hate this term hypersensitivity because it implies that the immune system is being overreactive. That's what hyper means. But in fact, it's the term, which is a traditional classical term, hypersensitivity, refers to when the cellular immune response is functioning normally to deal with pathogenic threats, cancer, etc. The symptoms, the pathological symptoms you experience as a result of this is due to a visible inflammatory response through cytokines, through complement activation, etc. And these processes happen during antigenic threats like tumor rejection. If you get a allogeneic graft, even in pregnancy, the morning sickness you experience is due to an inflammatory response of the immune system modifying the tissues to allow for implantation. So that doesn't mean that within this hypersensitive response, there are aberrant mechanisms going on, as in the case of autoimmunity. But don't get in your mindset that hypersensitivity is only due to a misdirected immune response. It's actually, call it collateral damage as a result of the normal functionings of the immune system. So the objectives of this lecture is to talk about the 4 types of hypersensitivity reactions, to talk about the pathological features and the clinical symptoms as a result of these processes, and then the mechanisms that we currently have for treating these situations. So we divide them into 4 types: 1, 2, 3, and 4. 1 is the classical allergic reaction that you all know about: hay fever, allergy to peanuts, shellfish. Some of you might be unfortunate enough to experience asthma. These now, types 1, 2, and 3 all involve antibodies. Type 1 sits by itself because type 1 involves the IgE antibody, and it involves Th2 responses, because Th2 cells, if you remember, by making IL-4, 5, and 13, induces B cells to undergo isotype switching to make IgE. Type 2 and type 3 are your classical Th1, Th17 type reactions, in that these reactions involve predominantly IgG and IgM. And these are induced by Th1, Th17 type T helper cells. Type 4 sits on its own because it doesn't involve antibodies, but predominantly cell-mediated immune responses, T helper cells and cytotoxic T cells. And again, this is predominantly a Th1, Th17 inflammatory type response. So we'll start with type 1, the allergic reaction. And I don't know, some of you in the class might have allergies, allergic to pollen, to the fine dust in the air, to various foods. And if you are known as being atopic or allergic. We don't really know why some people suffer from these. It's genetic, but we also have we're also starting to find out now that it can also be due to changes in the environment. The fact that allergic reactions, people with allergies, are on the increase. They've been on the increase for the past 50 years. And this is one of the current hypotheses is due to the fact that most of us in developed countries live in cleaner environments. I'll expand on that later. So basically, when a person who is susceptible to developing allergy, was atopic, gets exposed to the antigen, such as pollen, for the first time, they will not experience any symptoms. They only start to experience the classical allergic reactions of runny noses, sneezing, blah, 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 after second or multiple exposures after that. The reason is that the initial exposure results in sensitization of the person to cause the T helper cells, predominantly Th2 cells, to induce B cells to undergo isotype switching to make IgE. With subsequent exposure, the IgE binds to what we call the allergen, which is the antigen inducing the allergic response. So IgE binds to the pollen grain, and then predominantly mast cells and basophils, which have the Fc receptor for IgE, then attaches to these bound antibodies. The attachment of the antibodies to these cells induces the mast cells to degranulate and release autocoids like histamine, serotonin, prostaglandins, leukotrienes, and so on. These mediators then have effects on the blood vessels to cause vasodilation, to cause smooth muscle contraction, so you get fluid leakage and the classical symptoms of runny noses, itchy eyes, redness, and so on. Okay. Now, this is what is called an immediate hypersensitive response. And it's immediate because the symptoms are due to these preformed mediators within these granules of the mast cells and the basophils being released to cause these symptoms. So the symptoms can happen within minutes after exposure to the antigen. But with some situations, after the initial immediate hypersensitive reaction is dissipated, you can get a further inflammatory response which lasts for about 24 hours. This is called the late phase reaction. And this is where a cellular immune response is drawn in with regard to classical Th1, Th17 type cytokines. And this is due to the influx of neutrophils, eosinophils, releasing their mediators, and also to cause phagocytosis through and then activation of the PRRs and so on. So the initial immediate hypersensitive response is due to a classical IgE antibody binding to the mast cell, causing degranulation and then the symptoms. The late phase response is due to, remember when I talked in complement, I talked about factors like C4A, C2A, which which are classified as anaphylatoxins. Remember, anaphylatoxins are substances which induce anaphylaxis. Anaphylaxis refers to the most severe form of immediate hypersensitivity. So these anaphylatoxins are chemotactic for drawing in neutrophils, eosinophils. They induce mast cell degranulation, IgE promotion. So they increase or promote this type of response. Now, why do we experience this? Why do we have this reaction to these environmental antigens like shellfish, pollen, whatever? The clue is that, as I said, these are induced by Th2 cells. And if you recall in the lecture on T helper cells, the Th2 cells, by virtue of the fact that they promote IgE production, they cause the influx of eosinophils, mast cell degranulation. Classically, the Th2 response is directed against large microbes, namely parasites, parasitic worms, helminths, amoeba, that you usually take into your body by ingestion through contaminated water, contaminated food, or whatever. Now, when these parasites get into your mucosal tissues, predominantly the gut, you do not want a full-blown inflammatory cytotoxic damage to the fine epithelial lining of your mucosal barriers. Rather, you want expulsion of these parasites. So you want to create vomiting and diarrhea, so you will expel these microbes rather than to kill them, because in many cases, particularly helminthic worms, they're far too large for your normal neutrophils, macrophages to kill these things. So you rather just flush it out of your system. Now, this is all well and good if you're living in a countryside where these sort of microbes are present. But as I said, in the urbanized setting where we have cleaner sanitation, or better sanitation, clean water, we don't have these antigens. So instead, this type of immune system, this Th2 response, is more directed then to you could think of it as a cross reaction to antigens in the environment, like in the food or like in the air. Another clue, and this is what we call the hygiene hypothesis. And to support this, we also find that kids who are brought up in the countryside are less susceptible to developing allergies than kids who brought up in urban environments, because the ones in the countryside are more exposed to environmental antigens. So coming on to that, if you are brought up in an environment where there is more antigenic stimulation, we also hypothesize that you have better induction of regulatory T cells to control these type of immune responses. Now, the pathology of type 1 hypersensitivity is a spectrum depending on the nature of the allergen, and it can vary from the mild hay fever allergic type reaction of runny nose, itchy eyes, and so on, to a severe life-threatening situation, as in the case of people who have peanut allergies, or this particular most severe form, anaphylaxis. So it depends on antigen dosage and also the amount of these inflammatory mediators that are released. So in the mildest situation, like hay fever, where you get this burst of prostaglandins, leukotrienes, histamine being released by the mast cells, that is easily controlled through taking antihistamines or whatever. But if you, for instance, if you are severely allergic to peanuts and you take it into your gut, and that gets into the bloodstream, then you get the release of these inflammatory mediators, which become systemic. And so it can then generate these severe inflammatory responses in all the tissues and all the organs in your body. And then another type of life-threatening situation is in people who have chronic asthma. Because with asthma, where you have constant damage and then repair to the airways, this cycle of damage and repair results in scarification of the airways, which means that they get narrower and narrower, and so you get less ability to pass oxygen through those valves. So the treatment of type 1 hypersensitivity, again, depending on the severity. So you all know that for the common allergic reactions, you can take antihistamines to block the effects of these autocoids. In severe cases, you might want to inhibit mast cell degranulation through these drugs, these cromolyn drugs. In life-threatening situations, you'd use corticosteroids like epinephrine. And then for chronic type 1 hypersensitivity, this is still experimental, and I don't think it's being used commonly. But the idea is to try to either promote regulatory T cells or to divert the immune response away from a Th2 type reaction to a Th1 or a Th17. Why do you think that would be effective? If you have a Th2 type response that is promoting the creation of IgE antibody, why would you want to block that by promoting a Th1 or a Th17?
The IgE bind to mast cells.
No.
Th1 response.
Even before that, trying to divert the type of helper response. Remember that in the lecture about T helper cells, I said that Th1, the cytokines that Th1 makes, is in conflict with the cytokines that Th2 makes. So that interferon gamma, or the IL-17 made by Th17 cells, blocks the production of IL-4, which is the signature cytokine of Th2 cells. And the IL-4 513 made by Th2 cells blocks the production of interferon gamma or IL-17. And this is how you get predominant Th1 or Th2 type reactions. So by trying to divert the cellular immune response away from Th2 through the promotion of these Th2 cytokines, namely interferon gamma or IL-17, you can then skew the immune response towards non-allergic type reactions. For people who get sick of sneezing every time they're near a cat or whatever, what they can do is they go to an allergy clinic. And the first thing to do is try to determine what these people are allergic to. So what they do is the so-called skin prick test, where they will take some products from all of these different allergens and just scratch it onto the skin. So here you can see the control of histamine, which causes this characteristic, what's called a wheal and a flare reaction on the skin. And you can see that this person might be not allergic to bird feathers, but allergic to cats, dog hair, horse, pollen, and so on. This is a no reaction with a negative control. A lot of these allergens, too, I should add, are also due to mites which live in your homes or on your beds, what are called fomites, the feces expelled by these mites. So no matter how powerful a vacuum cleaner you have, very often you can't get rid of these things. So much for type 1 hypersensitivity. So now we go on to type 2 and type 3, which, as I said, involves IgG and IgM, both of which are complement fixing. Now, through the years, many students often get confused between what is type 2 and what is type 3. Basically, the general rule is that type 2 hypersensitivity reflects an antibody-mediated response against fixed tissue or fixed cell antigens. So these are antigens immobilized on the surface of, say, blood vessels or various cells. where antibodies are binding to them. Type 3 refers to circulating immune complexes. So these are soluble antigens which are circulating through the bloodstream or the lymph, bound by antibodies. So you get these floating large antibody antigen deposits circulating through the system. With the type 2 hypersensitivity, the pathology can take either of two forms. One is that if these reactive antibodies binds to the antigen, remember what happens in terms of innate immune responses when an antigen binds to, say, a bacterial cell surface protein. What reaction after that do you get for removing the bacteria? What are the four different ways? Give you a clue. The one is opsonization, right? What is the next one?
ADCC,
Sorry? Louder? Begins with a C.
complement.
Complement. Classical complement fixation. So when an antibody binds to an antigen, it will activate complement. You can get then through the downstream completion of the complement activation, the creation of C5, 6, 7, 8, 9 to create the membrane attack complex. And this can then kill or damage or destroy cells. And in this case, if they're blood vessels, they can damage the blood vessels. Right? So this is one mechanism whereby you can get pathology. And an example of this is this process called molecular mimicry, which I've talked about before, but I assume you've heard about this from microbiology lectures. So this is a case of a cross-reactivity, where initially you get infected with streptococcal bacteria. You develop an antibody response against the streptococcal antigens. The trouble is that those antigens are very similar to heart muscle. So your antibody response, which is directed against the bacteria, then start attacking the heart muscle and you get myocarditis, as in the case of rheumatic fever. Another form of hypersensitivity occurs with people who develop allergic reactions to penicillin. And this is due, penicillin is very complex because it can cause type 1, 2, 3, and 4 hypersensitivity. But in this situation, what happens is that when these penicillin drugs get into the bloodstream, they get broken down into smaller components. One of those components can then attach to red blood cells, creating a type of hapten carrier complex. And so you develop antibodies against red blood cells, and you can get anemia as a result. So that is one mechanism of the pathology in type 2 hypersensitivity, is damage to the cells or tissues due to complement. The other is where the antibody, if it is binding to particular receptors, acts like an agonist or an antagonist. So it mimics the effects of the ligand. And examples of this is in the case of myasthenia gravis, where autoantibodies bind to the acetylcholine receptors on neuromuscular junctions, preventing these receptors then from getting the appropriate signals from during the activation of these neural cells. So this is why you get paralysis in these peripheral tissues. The other is Graves' disease, where these antibodies act as agonists, where they bind to the thyroid stimulating hormone within the thyroid, so act like the hormone itself, so they activate these cells. And then with regard to damage to blood cells, type 2 hypersensitivity occurs in mismatched blood transfusions. So if you don't blood type properly and you infuse someone who is, say, type A with type B blood, you're going to get an antibody response to those B blood expressing cells, causing cell lysis. One way this has been shown occurs more in experimental animals. And this was how it was first discovered. But it does occur occasionally in the human situation, particularly in people who receive booster vaccination. So in the booster vaccination, what happens is that the person gets initial dose of the antigen, the vaccine, develops an antibody response against the antigen. But let's say that the immune response wanes after a year or so. So then you get another dose. When that happens, you still have some specific antibody in the bloodstream. So that on this secondary challenge with the antigen, those antibodies can bind, those preformed antibodies can bind to that secondary vaccine to create these immune complexes. As a result, because as a result of the immune complexes, they can then activate complement through the complement pathway, but not going fully to the membrane attack complex, but creating C3b. If you remember, C3b causes opsonization, but also many cells like neutrophils have receptors for C3b. So these complexes can then bind, causing neutrophils to degranulate to induce a full-blown inflammatory response. These, as a result of cleavage of C3, you get the formation of these anaphylatoxins, which can then induce mast cells, eosinophils to degranulate and create a histamine type hypersensitive response. And so this is the reaction you get on the skin. Luckily, it's not that serious. It can, all of these mediators can get diluted out after around 24 to 48 hours. So it's only a temporary thing. So type 3 hypersensitivity, which, as I said, is due to the circulating immune complexes, as opposed to the type 2, which is directed against fixed tissue antigens. One relatively common, well, it used to be relatively common situation of type 3 hypersensitivity comes with what is called passive immunization. I'll talk about this more in a later lecture about vaccines. But we have two types of vaccinations, what we call passive and active vaccination. Passive is where you inject a person with preformed antibodies against antigen, as in the case of blood venom, snake bite venom, or rabies, because what you want is, or even tetanus, where you want to infuse that affected person with preformed antibodies to bind to the antigen to prevent it from getting into the bloodstream or in the nerve cells to spread. All right, so you want to block or inhibit that right from the start. The way you get these antibodies is that you inject other animals like horses, sheep, with an inactivated form of these toxins to raise antibodies against these toxins. So then you then take blood from these animals and purify the antibodies. So now you have a vial of horse anti-snake bite venom or anti-tetanus toxoid, so that if a patient comes in the clinic, you can immediately inject them with these antibodies. The problem is that these antibodies, being proteins, are foreign antigens within the human body. So you can develop an anti-horse antibody response or an anti-sheep antibody response. And if this is severe, you get what is called serum sickness, where these immune complexes can then spread through the whole circulation as a result of your antibody response against these injected antigens. If these circulating immune complexes deposit on blood vessels, as I said, they can then activate complement, and so the complement can then damage the endothelial lining of the blood vessels. If these circulating complexes are passing through very fine capillaries, like in the kidneys, they can start to block those capillaries, and so then damage the kidneys. This is the case of nephritis. So the problem of class 2 and class 3 hypersensitivity is due to excessive antibody production or unwanted antibody production. And so if it is severe enough, the ways of treating, one is if it's severe inflammation, you want to reduce that so you can treat it with corticosteroids. If it is chronic, what you want to do is to remove those antibodies. So one way to do this is to subject the person to what's called plasmapheresis. Have you heard of plasmapheresis? So basically, that is a procedure where you wash the person's blood. Basically, you apply a catheter to the person that then passes the blood through a centrifuge. So it's basically filtering out all the antibodies from this person's blood and then infuses it back into the person. So you're trying to remove the antibodies. Another mechanism is to inject the person with normal serum from a healthy donor. We're not sure exactly how this works, but it does. But we think that by infusing with normal serum, you are infusing with normal antibodies, which are able to block the antigen binding abilities of these say in this case, autoimmune type antibodies, or maybe even compete with them. And then in very severe forms, we will try to remove any antibody producing B cells. And this is by injecting monoclonal antibodies against this B cell marker CD20. So essentially, you're killing off every antibody producing B cell. That seems pretty drastic, but even though these people then have a reduced ability to make antibodies, it's not life-threatening because the cellular immune response is still protected. Type 4 hypersensitivity, as I said, doesn't involve antibodies, but predominantly cytokines, inflammatory cytokines in the context of Th1, Th17 type responses. The situations where this happens is in the case of autoimmune responses, like rheumatoid arthritis, like systemic lupus erythematosus. Some women are allergic to jewelry, like copper. These we still don't quite understand how this happens, but it's thought that the metal ions in the jewelry that penetrates the skin can induce a cellular immune response, inducing Th cells to make inflammatory cytokines. The classical way of studying type 4 hypersensitivity responses is in the case of certain plants. In the US, I don't know if any of you have heard of a plant called poison ivy, which produces an oil which is so potent that as you just need a little speck to touch on your skin, and within 6 to 12 hours, your whole arm just swells up and just becomes a bag of inflammatory cytokines. Then you also, in the case of certain virus infections, like hepatitis B or hepatitis C, which has a high incidence of causing liver cancer. And this is due to, even though the virus itself, these viruses don't damage or are not cytolytic to the cells that they infect, what they do is they induce a CTL or inflammatory T helper response against the infected cells to cause cell damage. As a result of killing of these infected hepatocytes, you then get regeneration to repair or replace those damaged liver cells. This can go on over 30, 40 years. And with all those repeated cycles of cell damage and regeneration, you eventually get mutations within these newly regenerated hepatocytes to develop into tumors. And this is why you get such a high incidence of liver cancer in these patients. And then the fourth type is the cytokine release syndrome caused by superantigens, which, if you remember, through binding non-specifically to the MHC T cell receptor of T helper cells, not cytotoxic T cells, will induce superactivation of these T helper cells to uncontrollably make these inflammatory cytokines. You'll learn about this next year when I talk about autoimmunity, but one characteristic in chronic autoimmune diseases is that when you have this continuous destruction of normal tissue and releasing of self-antigen, what this can do is amplify the autoimmune attack because it's exposing more and more self-antigens, creating a bigger diversity of antigen specificity. So basically, you get an increase in cellular damage. This is just another diagram. You should know all about super antigens by now. So, in summary, this is just to summarize all the different types of hypersensitivity reactions: type 1, 2, and 3, which involve antibodies; type 1 involving predominantly IgE interacting with mast cells to cause the immediate response, but then the late phase response, which is more neutrophils, eosinophils, is drawn in more by cytokines. Type 2 and 3 involve IgM complement fixing IgM and IgG, where type 2 is associated with fixed tissue or fixed cell antigens, whereas type 3 involves circulating immune complexes. And type 4 involves not antibodies, but the cell-mediated immune response in the form of the T helper cell and the cytotoxic T cell. Okay, that's it.